Good morning, my name is Valeria Arroyo. I am going to talk about low-dose methotrexate for the prevention of atherosclerotic events. Definition. Inflammation is closely related to atherothrombosis. Treatment with canakinumab, a monoclonal antibody that inhibits inflammation by neutralizing interleukin-1 beta, result in a lower rate of cardiovascular events than placebo in a previous randomized trial.
So the cardiovascular inflammation reduction trial, for me, is fascinating because at first sight, the implications are here's a negative trial, but actually it tells us something really interesting about the biology. We know that the IL-1 beta IL-6 pathway from the inflammasome is implicated on the basis of the previous CANTOS study. Now here's a different approach without selecting individuals at high CRP, using amount of methotrexate that was sufficient to influence the hematological markers, but it did nothing. And it did nothing to the IL-1 beta IL-6 pathway. So I think that this tells us that that pathway is crucial in terms of modifying inflammation and plaque behavior.
I was surprised it didn't lower C-reactive protein, and Dr. Ritker is the PI. So why did Dr. Ritker choose a drug that doesn't lower C-reactive protein to test? But it certainly is a nice trial to show that you can't just use any old anti-inflammatory drug. You have to use ones that meet specific pathways. And certainly with the results of the CANTOS trial, the IL-1 pathway appears to be the one to approach. But it didn't disappoint me or discourage me about the idea that directly targeting inflammation can still be beneficial for cardiovascular patients.
I think that with each of those trials, we've got to specifically look at that pathway. And we've got to look at the questions of, is the extent of dose sufficient to modulate that pathway in the plaque? Because if not, we may be facing another negative trial. There have been some interesting trials with colchicine already that look encouraging, but they were small.
And so I would like to have some sort of direct anti-inflammatory agent that has been demonstrated to help cardiovascular patients available to my patients. And then I'm also excited about the LODOCO 2 trial because colchicine is inexpensive. It's been shown to be very safe. It's already used for not only treating gout, but for treating other cardiovascular things such as atrial fibrillation and pericarditis. And so it might just fit right in if it becomes evidence-based by the LODOCO 2 trial. So I'm excited about that. And I'm also excited about other agents that might be targeted now that people know which direction to go. There have been other anti-inflammatory agents that have not worked, and so now we might have some that will work, especially now that we should probably concentrate on the IL-1 pathway.
Application in medicine. A randomized double-blind trial of low-dose methotrexate or matching placebo in 4,786 patients with previous myocardial infarction of multiple coronary disease who additionally had 8 type 2 diabetes of the metabolic syndrome. All participants received 1 milligram of folate daily.
I'm Peter Block in Chicago at the AHA annual meeting for On the Scene. With me is Paul Ritker. Paul has done a lot of work. He's at the Brigham in Boston and has done a lot of work over his career on inflammation. So Paul, I'm not going to ask you specifically to talk about your trial here, although we will talk about that. But give me sort of a background and an update. Where do we stand with this inflammation versus coronary disease and atherosclerotic disease business?
Well, Peter, it's really been a very exciting year and frankly a very exciting decade. We now know that the atherosclerotic process is driven as much by this pro-inflammatory response as it is by hyperlipidemia. Clearly lowering your LDL is crucial to beating this disease, but we have data that says even if you took your LDL down to 20, so high intensity statin plus a PCSK9 inhibitor, the residual inflammatory risk, that is the CRP, has not been touched at all.
Okay,
so we have to start from there.
So enter the CANTOS trial, right?
Well, I would say we have to kind of say, what do we know? We know that statins are lipid-lowering anti-inflammatory drugs. I think that's why they're so phenomenally successful. And PCSK9 inhibitors are pure LDL drugs that don't have an inflammatory effect. So CANTOS, reported just a year ago, was our first attempt to address what does inflammation inhibition do? Narrow spectrum interleukin-1 beta inhibition, that lowers interleukin 6, that lowers CRP, and it lowered major vascular events by 17%. So that told us we know the pathway of effect.
And that, in fact, Paul, was a bombshell a year ago, finally showing, after a long time of trying to prove this, that the inflammatory pathway is important. So now we have additional information, which is really very interesting.
Well, there's two pieces. The first piece still comes from CANTOS, which was not only was that pathway crucial, but the magnitude of the inhibition of the pathway for individual patients drove the benefit. So with canakinumab, the IL-1 inhibitor, the people who got the largest reduction in IL-1, IL-6, and CRP got sequentially larger benefits.
Right.
So now we turn it around. With NHLBI funding, we did the cardiovascular inflammation reduction trial, which was using low-dose methotrexate, commonly used to treat rheumatoid arthritis, an effective drug for RA, which, by the way, canakinumab is not. So these pathways are already different. And as it turns out, 5,000 patients later, multi-year study, very well done, no change at all in interleukin-1, interleukin-6, or CRP, and perhaps as a consequence, no change in vascular events. So actually, we look at CERT as an incredibly informative, neutral study telling us, since we know inflammation is real, since we have proof of principle of the inflammation hypothesis, now we know exactly what the pathway look in.
So in fact, going forward, and you and I have talked about this before, so we're cheating here a little bit, but going forward, now you have a target specifically that you can try and aim for with drugs that hopefully will show us exactly how it can deal with atherosclerotic disease.
Right, well here's what's so exciting. Honestly, every pharmaceutical company in the world right now understands exactly what's going on here. We need to find an orally available, relatively inexpensive way to inhibit this IL-1 to IL-6 pathway. We now know that's the target. There's ways of getting there. You can go one step upstream to what's called the NLRP3 inflammasome. It's a lot of words, but it has to do with where the IL-1 is generated. You can go downstream to interleukin-6, where we already have drugs that do that. We use them now to treat inflammatory bowel disease or Crohn's disease. And that is magnificent. It's kind of like when we figured out that HMG-CoA reductase was the pathway for lipids. We've got the pathway for...
Pros and cons. Pros. Methotrexate is an inexpensive, effective, and widely used treatment for inflammatory conditions. Cons. Methotrexate did not allow interleukin-1 beta, interleukin-6, or C-reactive protein level. As-in was associated with elevation in liver enzyme levels, reduction in leukocyte counts and hematocrit levels, and higher incidence of non-basal cell skin cancer than placebo. Use in bleak in Ecuador. Methotrexate did not allow interleukin-1 beta, interleukin-6, or C-reactive protein level protein than placebo. The final primary endpoint occurred in 201 patients in the methotrexate group and 207 in the placebo group. The original primary endpoint occurred in 117 patients in the methotrexate group and 167 in the placebo group. Methotrexate was associated with elevation in liver enzyme levels, reduction in white blood cell count and hematocrit levels, and higher incidence of non-basal cell skin cancer than placebo. In conclusion, patients with stable atherosclerosis low-dose methotrexate did not reduce level of interleukin-1 beta, interleukin-6, or C-reactive protein and did not result in fewer cardiovascular events than placebo.
The
Cardiovascular Inflammation Reduction Trial, or CIRT, was funded by the National Heart, Lung, and Blood Institute as one of 2 studies that my group did to really try to understand, can we test directly the inflammation hypothesis of atherosclerosis? The other trial, of course, was CANTOS, reported 1 year ago, which showed that if we gave a narrow spectrum anti-inflammatory drug that inhibits interleukin-1 beta, we lower IL-1 beta, we lower IL-1/6, we lowered CRP, and we got a 17% reduction in major adverse cardiovascular events. But the Methotrexate trial, the cardiovascular inflammation reduction trial, was asking, could an inexpensive generic drug deliver the same benefit? But remember, the mechanism of effect of methotrexate is actually not known, even though this drug has been the first-line agent to treat rheumatoid arthritis for the past 40 years. Bottom line, we randomized just shy of 5,000 patients across the United States and Canada who had a prior myocardial infarction or multivessel coronary disease, who also had to enhance their risk, either diabetes or metabolic syndrome, to either low-dose methotrexate, 10 to 15 milligrams given once a week plus daily folic acid, or to placebo plus daily folic acid. All the patients were very aggressively treated. The baseline LDL cholesterol was only 68 milligrams per deciliter. But we did not screen for the CRP, which we had in the CANTOS trial, and here the CRP levels came out to be normal, 1.5. At the end of the trial, we saw 2 fundamental findings that are really important for the biology of this field. First, while the methotrexate altered the blood counts, altered the infectious issues in the direction we would expect, we saw no change at all in interleukin-1, interleukin-6, or CRP. And perhaps as a consequence, we saw no reduction in cardiovascular event rates. Now actually, some people have said to me, well, Paul, are you disappointed by that finding? Actually, it's very exciting to us, because what we've learned in the context of CANTOS and CIRT taken together is an enormously important piece of biology for the future. 10 years ago, we didn't know what pathway might be involved in this atherosclerotic process. We just had an instinct telling us inflammation is important. Well, today, after these 2 trials are now reported out, we know 2 very important things. First, CANTOS has given us proof of principle that inflammation inhibition, without changing blood pressure, without changing lipids, clearly can lower cardiovascular event rates. And the neutral data in the CIRT trial tells us the pathway must be through interleukin-1 to interleukin-6 to CRP. Why is that exciting? Well, that's telling us exactly where the future is going to sit. If you think about this broadly, when cholesterol drugs were first developed, we had to figure out, how do we find the HMG-CoA reductase pathway? This is analogous to that today. We now know that overwhelming likelihood is that IL-6 itself is a causal agent in atherosclerosis. We have that data from Mendelian genetic studies, we have that data from vascular biology, and now we have 2 clinical trials telling us if you do inhibit that pathway, it works, and if you give an anti-inflammatory that does not inhibit that pathway, it doesn't work. So as a cardiologist thinking about drug development, we can move upstream 1 step to what's called the inflammasome, and there are oral agents being developed there. We can move downstream 1 step to IL-6 inhibitors directly, and we already have drugs that do that. And so the real question now becomes, can we find inexpensive, safe agents that are really going to add to lipid lowering to lower vascular event rates? So I look at this as 30 years of development. We started with an idea about inflammation, figured out that the high sensitivity CRP test can tell us who's at risk. We figured out that statins were lipid lowering anti-inflammatory drugs, and now we have proof that inflammation inhibition on its own will benefit patients. So the future is very bright for this field.